Hi and welcome to Esoc 2021. My name is Mira Katan. I'm a stroke physician from Zurich, Switzerland, and the chair of the current Scientific Abstract Committee of the Esoc 2021. It is my pleasure to introduce you to Dr. Signild Asberg and Jonas Oldgren, both co-PIs of the timing trial, which is investigating the optimal timing of oral anticoagulation therapy in patients with acute ischemic stroke and atrial fibrillation. So Signild and Jonas are both stroke physicians and cardiologists, respectively, from the University of Uppsala in Sweden. First of all, I'd like to congratulate you on the timing trial, which we eagerly awaited on the results, all of us, and I'm very pleased to be here to interview you both. So maybe you could tell me first about a little bit the study rationale and methods, and of course, then the results of the timing trial.
Thank you, Mira.
Thank you very much. Before going into the methods of the timing study, I have to mention the pre-timing study, which was a medical record review we performed in 2014. Which was vital in that sense that it gave us an estimation of event rate in Sweden at that time. It also gave us an idea of when NOAC or OAC, which was part of that study, was started in Sweden at that time. And the median time to start NOAC was 4 days. And that gave us the cutoff for the early arm versus the delayed arm, which is day 5 to 10. Yes, I think that if we go on from that, from the pre-timing study, that was also what we based our discussion on the non-inferiority margin, which is set at 3%. So the timing study then started in 2017 and was conducted at almost half of the Swedish stroke unit. And it's a registry randomized clinical study. We estimated the sample size of 3,000 patients, but we included 888 patients, so almost 1/3. So even though being fewer, the basic characteristics were well balanced between the two arms. We also, by using the registry, we had also access to a non-randomized patient, that is, patient that was not included in the timing study. And in comparison with them, we can still see about the similar mean age, around 78, 79 years, and also both in the study patients, both arms, and also the non-randomized patients, almost half of them were women. Other difference we could see comparing study patients versus non-study patients is that the study patients were newly detected AF and also had more reperfusion therapy. So by that, I think we move on to the more interesting part of the results.
Yeah, so the primary outcome in the timing study was a composite of recurrent ischemic stroke, symptomatic intracerebral hemorrhage, and death. All-cause mortality. And we chose that composite outcome because it's, of course, important to reduce the risk for recurrent ischemic stroke, but at the same time, we should not increase the risk for severe bleedings, especially intracerebral bleeds, which is still a risk even with NOAC. And of course, mortality is important both for us physicians and for the patients. So in the early group, we observed 31 events of the primary composite outcome in 450 patients, and in the delayed group, 38 events in the 431 patients. So the proportion having this primary outcome was 6.89% in the early group and 8.68% in the delayed group. And we know that non-inferiority designs are quite difficult to grasp, but the non-inferiority test is the risk difference between the early and delayed group. So the point estimate of the risk was minus 1.79% for the early compared to the delayed group, which is of course an advantage for the early group. And the upper confidence limit was 1.17%, which is way below the non-inferiority margin of 3% mentioned by Signild. So by that, we could conclude that early start of treatment is non-inferior to delayed start of treatment. And importantly, we have lost no patient to follow up. So we have follow-up of every single patient for 90 days and every event, of course. By having secured non-inferiority, we were also allowed to test for superiority according to the protocol and also to recommendations by EMA and other organizations. But early, we could not show that early was superior to delayed treatment. And then, of course, we look for the separate components of this composite outcome. And notably, already in the composite, we saw that many of the events occurred very early in the study.
Yes, and that was especially the ischemic stroke events that occurred just in a couple of few days from stroke onset, so which again highlights the importance of safe treatment in the acute phase after ischemic stroke. And also, yes. Please.
Sorry, maybe from the safety issue. So there was not a lot of signal for hemorrhages and bleeding events. So as I understood, maybe you can also say some few words on that side.
Yes, that is completely correct. There were actually no symptomatic ICH in the time study. And by symptomatic, we refer to a 4-point increase in the NIH stroke scale. We also looked at major bleedings, and there were not too many major bleedings at all. By lifting the NIHSS criteria, there were 2 other intracranial bleedings.
So overall, the safety was amazingly good, we believe, and so we have a promising result with this non-inferiority. And our interpretation of that is that it seems safe to start early, and there is no obvious need to delay treatment to have a safer time window.
Yeah, and I think that's a very important take-home message. And from the other side, now, if for clinical practice to advise the practitioners, as you already mentioned, non-inferiority trials are not so easy to grasp, but maybe what is the take-home message? Can we now skip the 3-6-12 rule, which has been used in clinical routine, although not based on randomized controlled trials? It's an expert opinion, but what's your take on that? And what are the unanswered questions and next steps from here?
So the take-home message from the timing study is that start early is not worse than starting in a delayed window. But another important message is that you still have to enroll in those trials that are still ongoing. We need more data and we need more information to really grasp the acute phase.
So, I mean, the strength of this study is that we have complete follow-up of every patient, and we also know that this seems to be a representative population of at least the Swedish stroke population, with patients having atrial fibrillation and starting NOAC treatment within the time window of the timing study seems to be rather similar to the timing patients. But we didn't show superiority. So we really encouraged investigators to enroll patients in the Optimal Zealand trials, for instance, and the STAR trial in the US, because we need to know even more.
Yeah, so thank you very much. I think it really was a pleasure to talk to you, and it's an important study, really interesting design, really, because the randomized controlled registry biased trial is a really new design in the world of stroke secondary prevention, and I think that's also congratulate you on that, and maybe this will take place further in other studies from there on, because there are obvious advantages of this type of design. And so I'm really happy that you were here and presented the important data of the timing trial at the Esoc 2021. Thank you.
Thank you.
Okay, thank you so much.